Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jacqueline Meredith. This episode features an expert discussion on how to manage patients with mild to moderate COVID-19, in particular patients who are immunocompromised. I'm joined by Dr. Martin Witzenrath from the University of Berlin in Germany and Dr. Michele Bartoletti from IRCCS Humanitas Research Hospital in Italy. This episode is part of a larger educational program titled COVID Rounds, Clinical Case Discussions on Best Practices for Inpatient COVID-19 Management. For more information on our faculty, along with a link to the larger educational program, please visit the link in the show notes for this episode. Now let's get started with Dr. Witzenrath.
So let's start with a patient case. We have a 45-year-old woman with recent diagnosis of mediastinal lymphoma, and she's admitted for febrile neutropenia and mucositis. She reports mild URI symptoms like cough and a sore throat that began 2 days ago. Her vital signs are stable. She's stable on room air. Her medications have been epoch rituximab. The last cycle was 2 weeks ago. Acyclovir, fluconazole, levofloxacin, and trimethoprim sulfamethoxazole. Her vaccination status was that she was completed an initial mRNA series. She was boosted in 2021, and she had COVID-19 in 2022, so 2 years ago. And now she presents with a positive COVID-19 antigen test. So the question here is now, which therapy, if any, would you recommend? But before we consider the therapy, we might want to do our COVID-19 diagnostic workup. And of course, it's of utmost importance to assess the severity of the disease and to reflect on risk factors for progression to severe COVID-19 in such a patient. We need lab testing. We already have a positive antigen test. We might consider PCR. We obviously need a CBC with a differential. We need a CMP and maybe other labs depending on the specific patient. We might want to have a chest CT to get an idea of the lung infiltration and an EKG, maybe other studies depending on the specific patient. Now, how are we going to assess for clinical severity? Most patients who enter the ER get a QSOFA done that includes a new onset of a confusion or a GCS, Glasgow Coma Scale, below 15, and a respiratory rate of more than 20 breaths per minute, and a systolic blood pressure below 100 millimeter mercury. For each of these criteria, you might give this patient 1 point in the QSOFA. However, this falls too short because in a typical patient with COVID-19, we frequently observe this sort of happy hypoxia. So patients do not realize that they have a low oxygen saturation, and they might have an oxygen saturation below 92% at room air, which would reflect a rather severe course of the disease already at that time. Particularly older patients or weak patients may not be able to produce higher respiratory rates, although they might need these higher respiratory rates to oxygenize their blood. So oxygen saturation again might be reduced in these patients. And then it's important to look for PCO2 because lower PCO2 levels might reflect hyperventilation and serum lactate levels that are increased might reflect a beginning of sepsis. These are unfavorable symptoms or changes that you need to consider. And then it's important to not only have a one-time measurement, but to consider unfavorable trajectories and do these assessments again and again over the next hours and days. Of course, also acute renal failure may reflect clinical severity, and it's important to reflect on comorbidities of these patients, as patients with pulmonary comorbidity, a cardiovascular comorbidity, or other comorbidities might experience more severe cases of COVID-19. And then, most importantly, severe immune suppression may increase the risk for an unfavorable trajectory. So let's go to the COVID-19 treatment recommendations. And here we have to consider the course of the normal COVID-19 infection. And this is that the patient comes in mostly with mild symptoms or maybe moderate symptoms. And at that time, he has already been infectious. And then the disease may progress to severe case. And we do have a lot of possible medications for these patients. We might consider antiviral drugs like nirmatrelvir, ritonavir, or remdesivir in inpatients.
So in the NIH COVID-19 guidelines recommendation for ambulatory settings, we generally, steroids are not recommended, but antivirals are highly recommended because they show that can reduce hospitalization and death for COVID-19. And generally, the most common antivirals are recommended are nirmatrelvir, ritonavir, or remdesivir. Molnupiravir could be considered as an alternative, but in most countries not available anymore. For example, in Italy, we cannot use molnupiravir right now because it's out of availability of drugs. In hospitalized patients, generally we stratify the treatment according to the needs for oxygen therapy. And in patients who do not need oxygen or supplemental oxygen therapy, steroids are not recommended because they can also, paradoxically, get worse in the course of COVID-19. Only in patients at risk of progression, guidelines suggest remdesivir. Remdesivir is also suggested in more severe cases in patients especially needs oxygen therapy or non-invasive treatment, but generally they're not highly recommended in patients receiving mechanical ventilation or ECMO. But guidelines suggest to consider remdesivir in a special situation. Obviously, in this phase, as Martin already said, we need also anti-inflammatory drugs. So dexamethasone is the most recommended as initial treatment for all patients that needs supplemental oxygen, but especially in patients who rapidly progress to more severe cases, baricitinib or tocilizumab can be considered as the additional treatment. I think that IDSA guidelines are pretty similar to the previous. They consider to use all in severe cases dexamethasone, remdesivir, and especially baricitinib or tocilizumab in rapidly progressive patients or in patients who are in a critically ill situation. Let's talk about drugs because we treat patients with drugs. So the first drug I'm going to talk is remdesivir. Remdesivir probably you know because it's one of the first drug we use for treat COVID-19. Most randomized control trials did not include immunocompromised patients. And I think it's very important to see what real evidence studies show about this topic, especially what the efficacy of remdesivir in this group of patients hospitalized with COVID-19. So this is an interesting study that was published in Clinical Infectious Disease in 2023, showing that when patients are immunocompromised and are treated with remdesivir, there's a reduction on overall mortality across all variants wave in the US. And this was confirmed for 14 days mortality and 28-day mortality. So again, we can say that this drug in the real world evidence seems to show a very high benefit to these patients. And also, what about patients that are hospitalized with COVID-19 not requiring oxygen? Because guidelines, this is something, a sort of gray zone in which guidelines not necessarily suggest to use antivirals, but just to wait to patient that become more severe and needs oxygen to start antivirals. But it's very strange because if the patient will benefit from the early stage when they are outpatient of remdesivir, why not they should not receive remdesivir also when they are hospitalized but not require oxygen. So this study that is more recent and was published in 2024, and is a retrospective multicenter study of adult hospitalized with COVID-19 who requires supplemental oxygen that receive remdesivir within 2 days from admission. And overall, this is a very large database. that the authors demonstrated that patients receiving remdesivir have an estimated reduced relative mortality risk reduction of overall 17 that was confirmed in the pre-Delta, in Delta, and Omicron periods. So, and this was also confirmed in just analysis with Cox regression, and so adjusting for all possible confounders. So, beyond remdesivir, we also have some other drugs, especially other antivirals. Nirmatrelvir ritonavir is another important drug that was censored just a few months after remdesivir. And thanks to the EPIC study that demonstrated that nirmatrelvir ritonavir for patients that are not hospitalized with COVID-19 did show really good effect on preventing hospitalization and death. However, when the second study was done recently, and this was published in 2024, a new study that was focusing on fully vaccinated patients and patients with standard risk, the early treatment was not more associated with any effect in terms of hospitalization and mortality. And as you can see, this is because the rate of hospitalization in patient receiving placebo was so low that they could not demonstrate a difference in terms of treatment effect. So probably, as said before several times, nowadays the landscape of treatment has changed a lot with vaccination, with previous infection, and probably now patients with standard risk has not more need for such antiviral treatment compared to before. So probably we should focus more on very severe immunocompromised patient, fragile patient, early patient, and patient with multiple comorbidities rather than standard risk patients. When we use nirmatrelvir ritonavir, which is still very useful for the patient with high risk, I think we should comment on possible drug-drug interaction thanks to the metabolism to the cytochrome CYP3A. And I suggest to everyone that want to start to use this drug to check for drug interaction. There's a multiple website you can check all drugs that can be prescribed together. Sometimes contraindicated, sometimes you can use with caution when these two drugs are used together. I think in the majority of patient cases, all the drug interaction are manageable. So, which therapy, if any, would you recommend to this patient? Based on IDSA and IHA guidance, all both drugs can be used. In this case, we have to consider that both drugs are very effective in controlling SARS-CoV-2, especially to preventing progression to severe disease.
Thank you to our faculty, and many thanks to you, our listeners, for joining in. As a reminder, to view the full program, COVID rounds, clinical case discussions on best practices for inpatient COVID-19 management, please click on the link in the show notes. And to get access to all of our new podcasts, subscribe to the CCO Infectious Disease Podcast on Apple Podcasts, Google Podcasts, or Spotify. Thank you, and have a great day.